Good morning and welcome to those present in the Council Chamber to the July meeting of the Health Scrutiny Committee for Lincolnshire. My name is Councillor Richard Cleaver and I'm the Chairman of this committee. On my right is my Vice Chairman, Councillor Chris Reeve, and on my left is Democratic Services Officer Josser Yates, and also present in the Chamber is our Scrutiny Officer, Simon Evans. For those of us in the Chamber, if we have a fire alarm, we need to leave the Council Chamber through the rear doors, then through reception and assemble in the car park at the front of the building and await further instructions, please. In addition to welcoming the members of this committee to the meeting, I would also like to welcome Councillor Bunny, Chairman of the Council, and Councillor Maria Hume, Executive Support Councillor, Adult Care and Health. Other participants will be introduced when we reach their item or when they first speak. The meeting is being live streamed via the County Council's website, and all your comments will remain accessible online after the meeting. With this in mind, I would like to welcome members of the public and press who are watching. Can I remind everyone to ensure that their mobiles, laptops and iPads are all now on silent. Requests to speak will be collated by the Vice Chairman. If you wish to speak, can you please raise your hand and we will make a note. When you begin to speak, please remember to switch on your microphone and most importantly, remember to switch it off when you finish speaking. Thank you. So moving into the agenda. Apologies for absence and replacement members. Apologies, Jess.
Thank you, Chairman. We've received apologies from Councillor Scalise. Also, I'd like to note that we have Councillor Corey replacing Councillor Kendrick, Councillor Armiger replacing Councillor Courier, and Councillor Passel replacing Councillor Higgs. Thank you.
Thank you. Welcome to them. Declarations of members' interest, item 2. Members of the committee are reminded that they only need to declare any relevant interests which have not been declared on their declaration of pecuniary interests form. Do any members wish to declare any interests, please? I'll take that as a no. I wish to declare or remind everyone that I am a Lincolnshire County Council appointed partner governor on the Council of Governors of North West Anglia NHS Foundation Trust. If you become aware of any interest at any point in the meeting, you can, of course, declare it then, as I'm sure you are aware. We now move on to item 3, which is the minutes of the meeting held on the 11th of June 2025. So we need to confirm that the minutes held on are a correct record. They can be found on pages 3 to 9 of the agenda pack. Do I have a proposer, please? Thank you, Councillor Mackinson-Saunders. Seconder, Councillor Morgan. Thank you. All those in favour, please show. All those against? Thank you. That's unanimous. Item 4 on the agenda is Chairman's announcements, which were circulated with the agenda as pages 11 to 27. And then supplementary announcements were circulated yesterday, the 15th of July. This is not an item for debate. These are purely for noting. Comments or questions are welcome, which of course will be recorded in the minutes. Does anybody have any questions or comments they wish to make on the announcements and the supplementary announcements? There's quite a lot of them this month. So, Councillor Mackinson-Saunders.
Thank you, Mr. Chairman. Whilst I understand why ULHT needs to increase their car parking charges, people from eastern Lincolnshire have very, very poor bus services to get to Lincoln, to get to the county hospital. And I really regret that, you know, people are being charged for being ill, which a lot of the time they can't help. So, I just think, whilst I understand it, I don't think it's right. And I think they really should reconsider people that have to travel perhaps 30, 40 miles to get to Lincoln County. And I'd also like to make a comment on maternity services. I live in Louth and people tend to go to Grimsby to have their babies. If you're not within that health authority, and we're in Lincolnshire, and it's in Goole and whatever else, they don't tend to get the same service as the people coming from within that trust, and it worries me. I have reported it to one of the maternity organisations, which they were going to take it up. But, you know, I run a baby bank, and we're trying to encourage as many mums as possible to breastfeed their babies. They don't get the same support and help at Grimsby, as they should do. And it does concern me, and if it's a good place to bring it up, I'm happy to support them.
Thank you for that. We do have the possibility of an item on maternity services to put on our work programme, and perhaps when we do consider that, we can consider, as well as considering our own NHS services within Lincolnshire, the effect of people travelling out of county. I think that would be quite appropriate. Thank you. Councillor Morgan next, please.
Thank you. I'd just like to follow on from that. I'm also receiving complaints regarding the parking charges, as you can imagine, in Grantham. And picking up the maternity issue, we lost our maternity unit, and I appreciate you saying that we will be looking at it in the future work plan. We have over 1,000 babies a year born from the Grantham area, and in fact we had very few less in Lincoln when the decision was made to make Lincoln in effect count the area where we should go. So we have no local maternity provision, and we are an increasingly growing town with more and more families moving into the area. It's hugely concerning. So I really am looking forward to seeing what's happening. In particular, what worries me is we hear about improvements, for example, to maternity services at Boston, but there was no reference whatsoever in that report to the, or even consultation with the mums-to-be in Grantham when that work was done.
Thank you for that. Councillor Lee, I believe, next.
Thanks, Chair. I'd like to make a formal request that we have an item on the work programme at some point, because we'll be talking about this later, where we go into some detail about the car parking charges, because it's a barrier to access. I think we need to know what comes in every year, what it's used for, actually, if it goes on patient services or what it does go. Absolute detail, because the other thing as well, you mentioned people travelling to Lincoln County Hospital. I'm not sure if everybody knows, but that's where Lincolnshire Heart Centre is. So anybody who comes in for a stent or anything like that in an emergency, they come to Lincoln. So, and people, from my experience, I worked on the cardiac ward, they came from Spalding and places like that. They come long distances. So there are a lot of people. I mean, it's pretty difficult to park full stop, but I do think that those charges are a barrier to access, and I'd formally request that we have some evidence and information brought to this committee about how much it recoups every year and what that money is used for, and how it is considered that benefits the patients and the patients' families. Thank you.
Thank you for that. I can add one piece of information to the issue, which is that the Trust has assured me that parking charges all go to the Trust, and the enforcement company only receives income from the fines.
With respect, though, Chair, that doesn't tell us what it's spent on. It just says that it goes into the trust coffers. It could be anything. And I'd just like, I mean, this impacts, at one point, staff had to pay. I used to have to pay £15 a month, and that was stopped during COVID, I think it was. And I don't even know if staff have to pay now. But there was also an issue where staff were dashing in at the last minute, perhaps couldn't find a space, and ended up with fines. I'd like a detailed item about this, about the cost of parking to staff and to patients and their families. Thank you.
Thank you. Any other comments? Councillor Martin, thank you.
Thanks, Chairman. Yeah, I fully agree with that, actually. A place like Grantham, for instance, parking charges means that people come to visit relatives and such like actually scatter amongst the community. They don't necessarily park in the car park, they'll park in the roads and surrounding areas. They actually park in one of the main park car parks, so they're actually taking up facilities that the residents would normally use. So I fully agree with that. It's a great idea to actually drill down into this and find out what's happening. As far as Lincoln County Hospital goes, I've been going there regularly for over the last couple of years visiting relatives, and the cost is horrendous over a period of time. And if I wasn't, if I didn't have enough cash and such, I would absolutely think twice about going to visit. So it's a real hindrance on people going to see relatives, which is not good. Thank you.
Thank you. Thank you, everyone. Your comments will be noted in the minutes. Any other comments on that or any other aspect of the Chairman's announcements? Because, as I said, there's a lot in there this month. Councillor Morgan again. Hello.
Yeah, just picking up a bit more about the charging, the car parking charging. I think something that the Trust can easily forget is the value of the visitors. When my mother was there, I ended up helping her off the toilet, helping to feed her, helping to dress her. And if those visitors don't go, that actually has a knock-on impact directly on the staff and on the patients and their well-being, not to mention the mental support that I was offering her as a visitor. And I think that you're almost being penalised for going to help, and I think it's a big mistake. Thank you.
Thank you for that.
Thank you. If we're going to ask for a review into where the spending goes to and all that sort of thing, could I also ask that as part of that, we look into what facilities are going to be improved there? Is there going to be any changes, as Scunthorpe did, make it into a multi-storey car park? Because, as many people have quoted, the parking is very limited and something needs to be done soon. As everything expands, we need to make some changes at some point. Thank you.
Thank you. Councillor Pessel next. Thank you.
Thank you, Chairman. I would just actually like to make a point of thanking the Lincolnshire, particularly county, for keeping blue badge parking free for those who have registered. I know, having extensive experience of many hospitals around the country, that this is not always the case, and that it does, of course, carry a cost to keeping that free. So it is to be applauded that they have decided to keep that free. I would just also like to, if we are going to move to a sort of review, that we query why motorcyclists are exempt from charging, because they take up bays and wear down the surface, not as much as cars, but they do take up capacity. So maybe that's one thing to be considered. Thank you.
Thank you. Thank you, everyone. We do need to move on, unless anyone's got anything new to add, please. Councillor Lee.
Thank you, Chair, and this is Scrutiny, so I do feel justified in making comments. Just to say that the improvements that I saw on car parking, and I worked there for 21 years till last October, weren't huge. For the staff, there was an area with gravel on it. We used to call it the beach. And honestly, if you went after a very early time in the morning, you really could not get parked. If you tried to go in the day for training, it was a nightmare. So I don't feel that an awful lot has been spent on improvements. But again, it'll be interesting to see that. Thank you.
Okay, thank you. Again, we've got our first speaker waiting. So can we just hurry up, please?
Yeah.
Thank you.
I'll be ever so quick. Could we in future, it's lovely to see a 10-year health plan, but how that translates into Lincolnshire, because this is a national plan, and I would like to see what difference it will make to our residents.
Yeah. Again, I think that's something that clearly we're going to want to put on the work plan, and we can do that later on in the meeting when we discuss it. Thank you.
Yeah, it's just a really quick one about the NHS Fit for Future plan. I think it looks excellent. There's some really good stuff in there. It's well worth a read. It looks at improvements in food quality, air quality, but also encouraging people to move and exercise. And I think that's going to be a dramatic shift. And it should be something that across all the districts and the county we really follow and keep a close eye on how to integrate that into what we're doing. So for anybody who hasn't actually read that, I'd have a really good read. Okay, thank you.
Thank you. I agree. It is a very good read, and I think we all should read it. And hopefully all understand it, and then we'll know what we need to be doing in Lincolnshire, I think. Okay, so moving on, thank you, those are noted, and again, your comments will be recorded in the minutes. Moving on to item 5, Lincolnshire Community and Hospitals NHS Group. This item was circulated as part of the agenda pack on pages 29 to 43. As this report introduces the committee to the full range of services provided by this NHS group in Lincolnshire, there is a potential for highly detailed and in some cases complex questions on particular services. With this in mind, I emailed all members of the group, members of the committee last week to ask for such questions to be considered in advance. Question and answers were circulated to members earlier in the week, and thank you for the staff of the Trust who responded to them for us so quickly. There were 2 advanced questions. I would like to advise that if our questions today raise matters of detail, the answers may not be available at this meeting, and obviously we'll have to follow them up. So the presenter from Lincolnshire Community and Hospitals NHS Group is Darren Fragley, I beg your pardon, who is the Chief Integration Officer. He's joining us online. Please, would you like to present your report to us in about 10 or so minutes? Thank you.
Yeah, thank you, Chair. And I'm joined by Anna Richards, who's our Deputy Director of Comms and Engagement as well. Thanks for inviting us to the committee, and thanks for allowing us to give an advanced paper on our report. So I'll take you through the highlights and then obviously go to questions. And as the Chair said, given this is a broad and overarching report about the entire group, there'll be components within here where I'm not a subject matter expert, but just to make you clear, my portfolio where I am a subject matter expert is community services, the 10-year plan and the integration into the neighbourhood health model, and I'm also the Chief Exec's deputy as well. So I'll try and answer all of the kind of big strategic questions or defer and come back to you with the answers. So as you know, Lincoln Community Health Services NHS Trust and United Lincolnshire Teaching Hospitals NHS Trust came together in a group in April 2024. So we've just gone over our 12-month anniversary. The first year of that was how do we get alignment between the two organisations, not only on the 3 sites that ULTH used to run, but also the community sites, community hospitals, and also the neighbourhood teams that we run across the county. The total income for the group is encapsulated within it, as is some activity data, both at a group level, but also at the 2 organisation levels as well. I think that the one thing to note is that the group essentially is an umbrella term for how we run the 2 organisations together, but the 2 organisations under the NHS statute still are 2 legally separate identities. And so we still have separate accounts, we still have a separate audit committee, albeit we do have a single leadership team now for the group and a single group board as well. So that's those are all of the things that have come together over the last 12 months. The group were in an exercise both with partners and also with the residents of Lincolnshire and also our own staff to come together with a new strategy. The strategy of which is in slide 3 of the report, which focus around better care, better opportunities and better health for our patients, people and population. And I don't plan to kind of read the detail into there. I think you can see that. But essentially an organisation there that's focused on population health and population outcomes as we move forward into the precursor of what's in the 10-year health plan, which is the neighbourhood health model. What I would say, and I did hear the kind of pre-asks of what does the 10-year health plan mean for the residents of Lincolnshire, and you'll recognise I'm using the term residents very deliberately, because if we're going to look at population health, we can't transpose our model into just looking after patients. We need to look after residents before they become patients, and also work with partners to look at that kind of whole population health system. So whilst the NHS is a supporter in some of these areas rather than a leader, we absolutely need to recognise that we've got something to bring to the table and work with partners on that whole population health approach. Principally, where we are trying to translate our version, the Lincolnshire version of the 10-year plan, is on that neighbourhood health model and left shift. We did get a question on can we have a key to what I would call the London Tube map, which is on slide 4 or page 4 of the report. But I'll just talk through this because I think this principally starts to unpack some of the detail of what we're trying to achieve. So as a resident that needs health from healthcare services, you will see that you know kind of we will be at home, bottom left hand side of the graphic, and traditionally now you have one of 2 routes for access to those services. You can either follow the purple line up and go to your GP and try and get access to primary care, and we know that we have challenges with access to primary care, largely because the demand is outstripping capacity, and a delayed appointment there, unless, of course, you manage to get one of the urgent slots or one of the paediatric slots, or where lots of people access the path of, dare I say, least resistance at the minute is following one of the blue or green lines along the bottom of the map there and into the centre, which is to our emergency department or our urgent treatment centres. Because let's face it, we are now a population that is 24/7, and the health service whilst is 24/7, largely is in an urgent and emergency care and not in our planned care services. So we absolutely know that we've got to move the front door and the access point of our services to the resident's home. And we absolutely know that we need to declutter that so that simplicity is, if you need support or you need help or guidance or access, we have the neighbourhood health model approach where we get that support to you at your own home where it's possible to do so. That doesn't mean that we won't need acute services. That doesn't mean that we won't need hospitals for the future. But what it does mean is that we bring as many services as we possibly can to you early enough so that you don't deteriorate and therefore need those services in the volume that we are currently seeing them. And that's the kind of neighbourhood health and neighbourhood team model that we are exploring. And one of the councillors asked, so what does that mean for Lincolnshire? We're happy to come back and do a kind of a detailed paper on that. But the little pie chart on the top of slide 5 gives you a brief summary of that. So bringing the group together and doing things once and doing them efficiently with the right level of care and outcomes that were expected means that we've aligned our services into that focus of avoiding acute pathways if we can by dealing with your preventative needs earlier, rather than having long waiting lists and then having residents deteriorating on those waiting lists, which means by proxy they need more quantums of acute care. And that's largely the blue section of the pie chart. The green section is developing that integrated neighbourhood team approach. So that's about having those multidisciplinary teams working with general practice, seated in the geography of Lincolnshire, and then dealing with those needs directly. So instead of you now coming to see a consultant in an outpatient appointment in a hospital, we are looking at how do we bring the consultants to GP practices and do those outpatient clinics locally, so you don't have to travel when it's not necessarily required for, say, diagnostic CT scans, etc. And so that's the neighbourhood approach. The left shift approach, the orange section, really is about how do we get those services plugged into those neighbourhood teams. So diabetes specialists, rheumatology, dermatology, respiratory, cardiovascular services, get them into the heart of general practice to work with GP, so we've got consultant advice as early as possible, rather than, as I say, getting to those individuals either through emergency departments or through planned care referrals and subsequent delays. And that's the work that we'll be working on over the next 3 to 5 year horizon, but we want to be moving services at some pace. And then the final bit is that alliance approach, which is creating an alliance, a partnership with some levers so that we can bring contracts together with partners such as St Barnabas, Primary Care, Age UK, just to name a few, some of the care homes as well, to start to say, how do we align these pathways and work as one team rather than segmented teams and obviously the barriers between. So that's where we're coming from a future perspective. More than happy to come back as requested and do a more detailed session on that as we develop moving forward. In terms of kind of what's happened over the last few years, so obviously ULTH, as it's now known, is a teaching hospital. It's got teaching hospital status, and I work with both Lincolnshire University and also the alliances with Nottingham as well. and we're looking to move that teaching status to the group over the next 12 to 18 months. Lots of investment in Lincolnshire. I think that broadly we've seen large improvements in both the performance, the offer and the credibility of our financial management in Lincolnshire now, which has put us in a much more favourable step nationally to get investments and be seen as a credible partner in the NHS for investments. And you can see several projects there where we've reaped the rewards of significant investments from that kind of trusted status. And if I pull out the CDCs as a working example of that, community diagnostics, so that's bringing things like diagnostic practitioners, CT scans, MRI scans, blood and culture work, therapists right to the communities that we serve rather than in the kind of acute hospital. So currently 3 of those, and then there's a 4th in planning, which is at Boston as well, and you see significant development there. We had a pre-question on Martha's Rule. I think we've answered that question, but happy to take any more if anybody's got anything else. In terms of our digital approach, we've got 2 new electronic patient records that are in now deployment, one for ULTH and one for LCHS. The reason there's 2 different ones is because the systems have different functions. So a hospital function is an episodic approach, appointment, in, out, length of stay, as the community one is more of a long-term health records that works with primary care. Both of those are in deployment phases now over the next 12 to 18 months. Happy to take questions on those. And nationally, there is ambition for a single patient record. Now, we have got a shared patient record already in Lincolnshire, but we don't use it enough, and there's plans to kind of work with that. So you tell your story once to multiple people through your shared patient record. A variety of other innovations in that section as well underneath digital, the work that we've been doing with endoscopy, with our community services and East Midlands Ambulance, which is really groundbreaking in how we offer services differently. And then looking at how we improve our efficiency on discharge. We've got a lot more improvements to do on discharge, and we're now starting the work of engaging with people that go through that pathway, because we know it's fragmented, and how do we make that better. So we are absolutely listening on where we go improvement wise. In terms of performance, urgent and emergency care it remains in an improvement phase. So in March, performance was in the upper quartile in the country at 78.2%. And continues to improve, largely the work we're doing with our urgent treatment centres and EDs. And also we're in the better half of performance nationally on our ambulance handovers as well, despite the fact that activity continues to increase. In planned care, we've got a lot more work to do. We know nationally the target's been set for a return to the 18-week standard. And we've got an ambition to set that to 65% by the end of this year. You can see performance month on month there, and opportunities for our improvement. And we're well on track with our long waiters there, although they're still longer than we would like. The post-COVID recovery is still absolutely in full sprint there. In terms of challenges, if I may, so obviously, the NHS is reinventing itself again. The 10-year health plan helps us because it sets that mandate. And fortunately, we'd aligned our strategy in advance of the 10-year health plan. So the strategy enables us to deliver that plan. The plan doesn't ask us to do something different. But obviously, the changes with ICBs will cause some distraction for us. And obviously, the reduction in headcount of the ICBs and on bigger footprints. And whilst it's challenging, absolutely the health plan is something that we need to do, but we shouldn't be under any illusion. This is a momentous shift from a service that's used to delivering through either GPs or through hospitals now to a service that's got to reinvent itself to use digital more in the community, more on resident health rather than on prescription. Financial performance continues to improve. Those of you that have looked at the group or the individual organisations for some time will know that we were an organisations that were in financial special measures. LCHS have been an organisation that's largely been in a reasonable place, but you can see that we've got an improving position on management of our finances. And then just for brevity, equally on all of our staff metrics, probably with the exception of sickness, all of those metrics are improving in terms of turnover and use of temporary staffing versus substantive staffing. The sickness challenge is one that's largely linked both to the pressure on the acute part of the system, but also on, as you manage the finances, the freedom for additional staffing becomes more of a challenge. So we're working hard on the sickness, as are all organisations across the NHS at this point in time. And then finally, if I may just finish on the CQC ratings, they're at the bottom of the report. What I would say is CQC in itself is going through a reorganisation. There'll be less of that large-scale CQC inspection where two coaches of inspectors pull up outside of an organisation and they scatter and do a whole organisation inspection, much now more to targeted inspections in departments. And if I tell committee that CQC actually, as of this very moment, are in the emergency department at Lincoln County doing an unannounced inspection, which is a follow-on from previous inspections before Christmas. And then finally, on the LCHS side, whilst their inspection measures are much more favourable to ULTH's one, their report is much older as well. 2018-19 was their report. So obviously, we would expect those to move as the situations and circumstances are largely different to where they were pre-COVID. So if I may, Chair, I'll rest there. Happy to take any questions, or I'll answer what I can in the report. If not, we'll take them offline and answer them at a time that's suitable for committee.
Thank you very much. Thank you for that. So we now move to questions. Please would members keep their initial questions short and to the point so far as they can, so we then have plenty of time for detailed follow-ups and plenty of time for everyone who wishes to take part to do so. So the first speakers who indicated is Councillor Lee, please. Thank you.
Thanks, Chair. It's a question, and I'll start by saying I'm very supportive of the NHS, passionate about it, and I think this neighbourhood model is absolutely the way forward. I totally support it. I want to raise something, though, because I want to know going forward what's going to happen. Live in the north of Lincoln, and if anybody needs wound care, say they've had a fall and damaged their arm or their leg or something, they cannot get that wound dressed at the GP. They have to go to one of, I understand 4 sites, but one of a number of sites to have it dressed. They can't get it done at the GP. And I looked into this, and apparently there's a number of GPs where this is happening in Lincoln. The ICB are blaming the GP and the GP are blaming the ICB, and I'm in the process of involving the MP and we're looking into it. That's not my question. My question is, going forward, if we're saying that care is going to come out into the community, going forward, would things like diabetes care, but wound care specifically, will that be at a GP centre? Because to me, if you've got to go out somewhere, and I'm told parking is really, really difficult at the sites, that's not accessible healthcare. And if we're talking about making it accessible, it needs to be at the GP. So going forward, will wound care be available at GPs? Thank you.
Thank you. I'm not sure that that's a question that Darren can answer, but would you like to have a go at answering it, Darren?
Yeah, actually, that's one I can answer. So, Councillor Lee, thanks for your question, and I understand the challenges that you face. I've had something else very similar reported to my teams. So, whilst I'm not going to wander into the GP component for obvious reasons, we don't run those GP services. Actually, what we do is we provide some of the wraparound services that need to work with GPs in the future. So the neighbourhood health model absolutely will move services like wound care into that neighbourhood approach. If we're being really kind of pragmatic about this, we're not going to be able to move all of the services from where they currently are and put them in GP practices, because they will just burst. But if you look at the 10-year health plan, it talks about creating these neighbourhood health centres. Now, at the minute, there's no capital back in those, so for us to build those, but we've got lots of people that are interested in working in partnership with us from a private perspective, people that we can work with. But principally, the core answer to your question is services that don't need an acute intervention in the future will not be delivered on those acute sites exclusively. We will still have those services on those sites if it's the closest site to you, but items such as worm services absolutely in that sort of space, and prevent that kind of the large geographical movements that our residents have had to face with the current model.
Thank you for that. I have Councillor Morgan next, please.
Thank you. I've actually got a few questions, but I'll try and be as fast as I can. First of all, with regards to your waiting time for diagnostics, appreciate that there are some issues still in that area. What does occur to me though is where patients are having to, for example, cancel appointments, they can't make it, or change them. The queues now for actually accessing, I rang 30 people were in the queue in front of me for an appointment recently. I'm wondering what resources we're actually putting in at that end, because the danger otherwise is we are having missed appointments, and you say the patient's responsible for that, but is it really, if they've tried to get through and just not been able to in advance change your appointment, freeing up a slot for someone else and speeding up your list? So I've got that question there. Readmission rates, I'm very concerned. Percentages hide figures, don't they? 976 patients we've readmitted within 72 hours of discharge. That is a significant number of people who were emergency readmissions. What are we doing to examine why and prevent those patients coming back? Because that tells me there's a failure in the system there somewhere. They should they have been released in the first place? You have to ask that question. And then the agency staffing figures, I notice, they seem to be not on target, and I just wondered, we're obviously heading in the right direction, so well done on agency staff, but I'm wondering how we've managed to still miss the budgetary target on that. If I stop there for now.
Thank you, Councillor Morgan. Darren, would you like to come back on those three questions? Thank you.
Yeah, if I take the one that'll probably be outside of my area, so we'll come back to you on the agency figures if that's okay. And we'll, Anna, if we take that way and get Claire Lowe to give us the detail of that. Having said that, the one thing I would say is our agency reduction plan is the best in the East and West Midlands. And lots of people are looking at how we've done it. So whilst we haven't quite got to the target, you have to question whether or not the target was something that was ever achievable. But we'll bring the detail back on that one absolutely for you. Coming to your first question then, so the diagnostics. Absolutely recognise what you're saying about the fact that we're creating, just by the volume of people that are going through these services, we're creating waits just by not lining up the diagnostics, or either we cancel appointments because we can't service them, or somebody's off unwell, or residents cancel appointments as well. So there are three things going on in this area. There's just been a pilot that I think we took 150 patients through to look at a different way of rebooking diagnostic slots, and the delays went from the low 50% up to 90% positive. So huge improvements we've seen just by doing booking slightly different. So we'll look at that and obviously talk to you properly before we do a rollout of any changes with any of those areas. But we know that our booking processes over the years, as things have got more and more complex, have become more and more fragmented. And often what we've got is the diagnostics comes too close to the actual appointment, and we've even had some examples of where the diagnostics have come after the appointment. We've had to cancel the appointment. So there's a whole piece of work currently going on about booking. Secondly, though, the other piece here is as the community diagnostic centres come online, we're starting to work with GPs now to say, do we do diagnostics before referral? So actually we get into a much better place where the diagnostics are done, and they're much easier to get to with this extensive capacity that's come online. But as you can see, you've got to get the booking right, you've got to get the access to the booking centres right, you've also got to get the capacity for the CDCs unlocked. So hopeful to bring quite a lot of improvements over a short space of time into diagnostics now, but absolutely take your challenge and question on board. On readmission rates, so first of all, what I would say is I'm completely with you, that number is way too high. It is absolutely way too high. What I would say, though, is whilst that's a whole number of 976, we on average discharge between 80 and 120 patients every single day, and that's a whole year figure. What are we doing about it, though? Because we would expect that number would be round about, typically national benchmark would be between 5 and 6%, so it's double where we would expect it to be. So we're doing three things at the minute. We've just finished a patient and carers survey to understand what's going wrong with the discharges and what do they need. And one of the biggest things that's come through is they don't get a follow-up call within 24 or 48 hours after discharge to check that they've settled at home well, or they haven't got a route to follow up. And then if people are anxious at home, which is understandable, they're coming back, and then we can't manage that, and then they get readmitted. So we're absolutely doing that ring back within 24 and 48 hours. We're starting that work now. Secondly, we are doing a piece of work to introduce a new discharge process, which starts to look at need on admission, not need on discharge, so that we can really make sure that we've got the discharge planning appropriate. And then the third piece of work is, and this is the beauty of the group, we can now plug the community services into the discharges from the acute services, so that we run it as a continuous pathway. So we're really hopeful that we'll get that number down to 5 or 6% in the next 12 months, just by now really getting to grips with what's going on. Hopefully those answer all of your points. Happy to come back if they don't.
Thank you. I have Councillor Pessell next, please.
Thank you, Chair. Three brief questions. Firstly, whilst the rates for the A&E were very encouraging, I would be curious to know what the occupancy rates are, particularly around Lincoln Hospital itself, but in a wider context, if that's available, and what impact that is having on processing rates for A&E. Secondly, you mentioned the changes in the patient records. As these changes are being put in place, will the inaccessibility from outside the area continue to exist? Because as someone who crosses health boundaries, having to deal with two or more sets of inaccessible patient records is a challenge, and hopefully as we're moving towards more national model, that sort of impediment can be phased out. And finally, you mentioned that you're bringing together your community contracts. Does that include hospices, and what is the current state of the hospice provision, and would you regard that as acceptable? Thank you.
Thank you. Darren, would you like to come back on that?
Yeah, thank you. So we'll come back to you with the absolute occupancy rates for both of the sites. But broadly, in answer to your question, both of the sites, both Boston and Lincoln, have high occupancy rates in our bed base, and as a result, we do see delays on the front door. So, as this morning, as a working example, there were 32 admissions that were waiting to come into the hospital that hadn't got a bed that was available because of the discharges we've got to get out first. So the occupancy rates are always in the kind of mid to late 90%, but they vary on a day-to-day basis. Hence why we're focusing so hard on getting the timeliness of discharge. If we actually overlaid the admission number against the discharge number, they broadly balance on a day-to-day process, but what happens is the admissions come in before the discharges go out, so you get that kind of bottlenecking in the middle. So one of the pieces of work we're doing on discharge at the minute is planning your discharge a day early, and then getting your discharges moving before midday. We are not good at that at all in Lincolnshire rather, and we're also not good at coordinating with transport providers to do that, because we use the same transport providers that do outpatient clinics as well. So you can see all of these things are linked, but we'll bring you the hard data. If we can get the discharge sorted, then you don't have that compression in the front door, and the occupancy starts to drop down in the emergency departments too. On patient records, 3 things going on in this area. First of all, we're absolutely cited on the fact, I think somebody was talking earlier about maternity care going north, but actually your holistic care being in county. So we're working with providers in northern Lincolnshire to align records, and that will absolutely be part of the EPR programme. And then similarly in southern Lincolnshire as well. So I was in the DP's practice only 3 weeks ago, where they're saying that people have their emergency care in Peterborough, but they come back and then have their community care and their planned care in Lincolnshire, and the records don't talk to each other. So digital's in my portfolio, and we're working on how do we link the records together. So that's part 1 to do that. Part 2, and you'll see it in the 10-year health plan, is that there's an ambition from, I think it was 2028, 29, to procure a single health record for the whole of England. Now, that is a huge task, and those who watch the NHS long enough have seen that task was tried kind of 10, 15 years ago and failed badly. But I think kind of there's going to be another go at this nationally, and it's absolutely needed for those cross-border works. But we're going to put a local solution in the interim, because there's quite a lot of jeopardy in that space. Finally, on community contracts and hospices. So one of the pieces of work we're doing with the ICB is bringing all of the funding and all of the focus for our end-of-life services together under the group, and then work with partners like St Barnabas, Marie Curie, Butterfly, to name but a few, but not exclusively them. In terms of our hospice cover, so the services that we have got work very well. Have we got geographical coverage across all of the answers? I think unreservedly the answer to that is no. So we did offer beds, for example, at Gainsborough a few years ago, but some of the reconfigurations we've had to do with the buildings at Gainsborough mean that we've had to withdraw those beds. We're working to re-establish those. It was only 2 beds, but it was for local people, so it's absolutely important we reset those. But what I propose, Chair, as long as you're happy with this, is to seek to put something about our end-of-life plan on with your permission, the work plan on future dates, and more than happy to come back and tell you what we're doing in this area.
Thank you. We have Liz Ball next. Thank you.
Thank you. And thank you for your paper and presentation, Darren. I think you've alluded to some of my questions from a Health Watch perspective. You talked about discharge improvements in terms of your last set of questions, but from Healthwatch, we're finding that we've got multiple examples of delays in hospital discharge. I think you've alluded to the transport, but around care home packages again, and you talked about the improvements. So I wondered if you'd be able to expand a little bit on what's happening regarding those improvements. Thank you.
Yeah, of course, and thank you, Councillor Ball, for the question. So we were only yesterday talking about this insider group in our quality committee and the plan that we've got for kind of discharges, and so the approach that we're taking is that, you know, kind of walk in the shoes of the families, the patients, and the carers, and see what that journey looks like, so that we can correct that pathway. So we know that people wait too long for discharge. Sometimes people deteriorate because they've got functional decline in our beds. We absolutely see that. And then we take too long to coordinate those packages of care. Now, what I would say is the packages of care are more challenged in your own home than they are actually in care homes. So one of the pieces of work we're actually doing with the local authority at this point is to re-procure our transitional care beds, so that we can release more capacity for that following individuals back home and having a functional discharge to assess. At the minute, our discharge to assess capacity allows us to look after 70 people or 70 residents at any one time on our discharge pathways. The changes that we've done by the end of January will allow us to look after 240. So it you know, kind of nearly triples our capacity in that area. What that then also does, though, Councillor Ball, is it takes off the inappropriate discharges to the care homes where people get delayed and therefore need bedded care. So it decongests that part of the discharge, because we know at the minute we're over prescribing discharge packages because of a lack of availability in the discharge to assess or the home care piece. So hopefully that gives you some reassurance at this point, and we'll give you the assurance when the numbers start to change and we can show you the delivery of the plan.
Thank you. Councillor Martin, next, please.
Thank you, Jim. Yeah, hi, Darren. Thank you for that report. I've been fortunate enough, or unfortunate enough, to have followed a patient journey of a 90-year-old gentleman several times over the last year or so. And to be quite frank, from the GP through to ambulance journey to A&E, waiting at the hospital, to hospital admission, care, then back to the care home, then to home and LCC services. At virtually all points along this, there are faults, and they're big faults. I could almost write a book about how bad most of these services are and most of the issues that have occurred. There seems to be a massive lack of listening to the patients and indeed your staff. I've had ambulance teams tell me how nobody listens to them, how they sit in A&E waiting for hours and hours in sweltering heat. They've got suggestions galore about how to improve services. They say nobody listens to them. I get similar things on the wards. There are issues constantly throughout the system. And when I read these reports and it's sort of more positive and helpful, it looks great on paper. But to be quite frank, I think the entire system needs almost a thorough review, and it needs to listen to people. So my question to you is very straightforward. What's being done to actually listen to the patient through their journey through the system? Go and talk to your staff. I sat in the back of an ambulance 2 weeks ago talking to members of staff, and they basically said they've got loads of ideas, they know what's going wrong, nobody wants to know. So at what point are you going to actually listen to the members of the ambulance teams, the staff inside the hospitals, and do a thorough review of what people are actually experiencing? Sorry it's so negative, but unfortunately that's what I've seen. Thank you.
Thanks, Councillor Martin. And first of all, please don't apologise for a kind of a negative question, because if we don't take those and turn them into learning, then we're frankly not doing our job. And just to add some context to that, you know, as a board member of the group, I equally sign off complaint responses on a weekly basis that show fragmentation in our journey. and also opportunities where we can, should and need to improve. And I would say my response is very, very simple to that. I showed you the London Tube map right at the very beginning, and then kind of at the minute we ask people to navigate that system themselves, and that's what the NHS has become over the last 20, 30 years. As it's got more complex, we're expecting people to navigate, and we've got multiple organisations that are then got, you know, things like referrals, waiting lists, callback numbers, all of those sorts of things. So that the whole system has got way too complex and way too difficult. The inception of the group was to remove the barriers between the two organisations. The inception of the alliance and the partnership is to remove the barriers between primary care and ourselves. And you can see that the 10-year health plan absolutely legitimises our drive to get on and get that done as well. In terms of listening, you can always do more. You can absolutely always do more. And even if I think we've got perfection, you will always find an example where you prove that we haven't got perfection. And I completely accept that. But equally, I think I've given 3 or 4 examples today of where we're actually walking in the shoes of residents and taking their learning on board to improve. The complaints every single week that we sign off, we take those and seek to improve. And similarly, so you won't know this unless you've looked at my bio. I am an ambulance man, I'm a paramedic by heart, and I equally would be able to sit with the crews at the front door of our departments and listen to their views as well. We do listen to the crews. Do we listen to every single member of staff? Well, we try to, but we'll always find one that we can't listen to. But we can't do enough listening, it'd be the point, and we absolutely know we've got to do more. So you can take commitment from me that we're, you know, if you have examples where people are coming to you and saying that they haven't been listened to, share them with myself or Anna, and we'll make sure that they are listened to. But we've still got a lot of room to go.
Thank you. Thank you for that. Councillor Morgan, you'd like to come back?
Thank you. I've got a few more points actually, but first of all, I've got a question. It says in section 4 of our report that you're talking about reaching a target of 78.2% in March for waiting times to be seen and treated. Why isn't this mentioned? What isn't mentioned is the admission waiting times for from the A&E to the wards, that key journey. In October 24, Councillor Wesley had cause to be in A&E with her 85-year-old mother twice. She experienced a total stay in A&E for over 30 hours, and then the first time, and then the second time, 24 hours. And readmission was less than, going back to my earlier point actually, the readmission was then less than 24 hours from being discharged. So Councillor Wesley's mother walked in with chest infection, and by the time she got to a bed, she had pneumonia and acute heart failure. Despite being diagnosed in A&E and prescribed antibiotics 15 hours after arriving, she didn't actually receive treatment for a further 24 hours. A&E was full of elderly patients waiting for beds, sat on hard chairs with deteriorating conditions. They hadn't been fed, they weren't given regular drinks. Most of them were being cared for by the people with them, such as Councillor Wesley, which only exacerbated the situation and the crowding in the A&E. One gentleman who was on his own had to be resuscitated in the middle of A&E, and when another patient alerted staff only. It was chaotic at best, and there was little in the way of compassion for patients and complete lack of dignity. What are the plans to reduce this? It's a real problem, and covered in a way by the current stats, and to provide adequate and suitable care for those patients who've been admitted and are waiting for a bed. So you almost need like a holding area. So what's being done around that? I can't help but wonder, if I may follow up on that, if we actually look at the CQC figures, if we look at the urgent and emergency services at Lincoln Hospital, they do not look good. Let's face it, they require improvement across the board, except for caring, which is ironic given the report we've just got there. So I do wonder why we are pushing more and more people into the A&E at Lincoln when it's clearly struggling. And I think there's a big overriding question there. If I might, I actually might have a solution for you. My old job, I was a business improvement consultant, if I actually can come up with one. Picking up the issue about listening to your staff, what's really important is that you record those comments, you act on those comments, and you report back to the originator of those comments. If you're not doing that, they haven't got evidence you've listened to them. So I just want to give you that support there.
Thank you, Darren. Would you like to come back on those questions?
Thanks, Councillor Morgan. And first of all, if you want to, or if Councillor Wesley wants to take that kind of relatives journey offline, both either Anna or myself are happy to have a conversation about that, because clearly those weights are not acceptable. First of all, what I would say is through extreme pressures that we face, and we all know when we get those, when the weather gets really hot, during winter surge, during flu outbreaks, etc., far too many of our residents use ED as the point of first call. And often that's because trying to access other services are either unavailable or become overwhelmed really quickly as well. And therefore, I think this whole session I've been talking about how we turn this inside out for the future, so ED doesn't become the pressure release valve, I suppose, that shows that the system is really challenged. But when that pressure happens, we do have very long waits for admissions in our EDs. I do have to say that the kind of over 24 36-hour waits now are becoming less and less prominent, although last year they were still there. In a previous system I've worked in, particularly on other waits, they got 3, 4, 5 days as well, and equally they're all inappropriate. There's now a new national standard to reduce waiting times below 12 hours, and we will be held to account for those moving forward. On the point for compassion for patients, what I would say first of all is I don't know a single person in the NHS who comes to work to do a bad job. But actually what happens is the pressure that's on the system, often things are missed when people get really busy, and unfortunately in some instances that busyness is interpreted either as a lack of compassion, or the simple things that make big impacts are the things that slip first, like sandwiches and drinks, etc. So we work really hard to deal with that, and we would encourage escalation if anybody ever sees that. The part of the CQC visit just before Christmas was sitting down and testing whether our staff felt that they were listened to. And actually, I don't know whether Anna wants to come in at the end, but the CQC view from that was that the staff had got a feedback loop and they were listened to. We didn't get it right all the time, but we're absolutely working on that. And then I think that the final thing is holding areas, I think, are for an NHS of the past, not for a future. Holding areas are just to move the problem somewhere else. What we need to do here is get the flow right, reduce the demand on these departments, and deliver the right care in the right place at the right time, and not essentially corral people in emergency departments, which is what's currently happening. Anna, do you want to pick up the engagement point, please?
Yes, happy to do that, although I think you've mostly covered it. But yeah, I mean, I think that we do have some pretty effective feedback loops, particularly with our staff. And you're right, Darren, I think visits that we've previously had more recently have highlighted that. I think, so Darren would tell you that we have a very frequent Ask Our Exec session with our staff, where any members of our staff can dial in and ask our questions and raise points with our executive leadership team, and that is so popular we've had to increase the frequency of it, and also don't get through all the questions all the time and have had to increase that. I think that's just a really good sign of the fact that our staff are feeling free to raise things and ask questions, and also feel like they're being listened to. There's always more we can do in this area, and I definitely think that there's particular pockets where we need to do more. We're doing some staff engagement roadshows. We are very proactive out with our staff, and I think Councillor Morgan, you made a really good point around not only listening but then feeding back about what we've heard and what we've done about it. So that's something we're working on. It's improving all the time, and people are noticing.
Thank you. Thanks, Anna.
Thank you. We have Councillor Lee again, please. Thank you.
Thanks, Chair. I've got a question, but I would just say I've taken part in those things where people dial in and they're really good, and it is no holds barred. You can ask what you want. And there's the staff survey, and if you don't answer the staff survey, you just get about 20 reminders until you do answer the staff survey. So they do get feedback. My question was around streamlining, improving the discharge process, because I would absolutely agree that that needs to happen. But my question is, are you organising staff in a different way or allocating different staff so that those discharges happen earlier and in a better way? And I've been on the other side as well, waiting for my son to be discharged. Because my point would be, a nurse starts their work at 7:30, they start a medication round. That goes on till about 9 o'clock by the time you've done IVs and insulin and stuff like that. Then it's the ward round, and you've got to go. There's an expectation, as there should be, that you go as a nurse round with the doctor on the ward round. That can take a couple of hours. And then somebody wants you to look at the pressure areas of a patient, because you have to document to say that you've moved them and you've seen them. So there's all these jobs you've got to do, and that you've got someone saying, "Oh, have you started doing that discharge yet?" When actually, my question would be, well, I used to say, what do you want me to leave so that I can do that discharge? What should I leave and let someone else do that? My question to Darren is the staffing going to be different in some way? Not necessarily extra, but will there be somebody who will be allocated to facilitating discharges in the morning? Because there are things you can do the day before, like book the transport, make sure the drugs are ready, or most of them are ready, that sort of thing. But there are things that actually need doing on the day, and staff have only got one pair of hands. And I would speak up for them here, because people do complain about what's wrong, but I can tell you now, nobody goes to work to not do a good job. And we used to sometimes, if we'd had a particularly bad day, we'd sit in the resource room, the staff room, and we'd cry and say, "I failed." And that's how it makes you feel sometimes. So I just needed to say that too. Thank you.
Thank you, Councillor Lee. Darren, I'd like to come back on that.
Yeah, thanks, Councillor Lee, and thanks for your kind words as well. I'll take that back to the teams. I'll be most grateful. In terms of streamlining and then staff then, so yeah, it's a cracking question, and it's at the heart of what we're doing. So you all recall, discharge planning currently starts at the point at which we've got line of sight to discharge, and then we spend either a day or a couple of days then planning the discharge. Not quite like it was a surprise, but certainly like it was the next task in the list. Where we're now working is taking some of the best practice from organisations that have fixed this, and fixed it substantially by doing something that they call preemption. So on admission, you actually work out what are the discharge needs, and then 72 hours before that individual is ready to be discharged. So it means you've got to get your discharge ready dates right, but 72 hours before the discharge planning actually starts. So you've got everything ready the day before: transport, medication, coordination with packages of care. Obviously, this is more on your complex patients. On your non-complex patients, you might not have 72 hours because they're not in, but you still start the planning on the day of admission. Secondly, as we speak, there is a new oversight system that's going in called Optica, which gives us that live dashboard approach where everybody is on their discharge processes. And then finally, what you would have previously known as the discharge hub or the discharge team is now being redesigned as a transfer of care hub. So it's not a discharge anymore, it's transfer of care to the next part of your journey. And that is largely a multidisciplinary approach with the local authority and with third sector partners as well. And so what it does is it just reorganises the jobs that the staff have to do, so you don't have that rush that you very eloquently described. So we're really confident, based on the fact this has worked in lots of other places, that we're going to see some improvements. And I'm not usually so forthright about the improvements, but this one, we're really confident we'll be in a good place.
Thank you. I have Councillor Mackinson-Saunders next, please.
Thank you. Well, I come here to represent East Lindsey, which is the largest district in the county. I read the positive developments, and all I can see for East Lindsey is that somebody's painted one of the patient environment rooms at Skegness Hospital, and we always feel that we're the very poorest relations in healthcare in the county. And I'm just really sad to read that we don't have any positive developments. Actually, there is one or two I could have listed for you. And there's the Centre for Future Living at Mablethorpe, which has just opened, which is going to further rural health. And that could have gone in here. But I'm just sad that we don't get a mention, and we don't actually see where the improvements are coming for our residents. Going on for waiting time for diagnostics, one of my councillors actually had his MRI scan. He cannot get the results from his GP. He's been waiting for weeks and weeks to get an appointment with the GP. It doesn't seem important to the GP, and he's saying, can I ask for the results to come directly to me? So it's not the waiting times to have the diagnostics, it's the next bit along the line, which is failing. Thank you.
Okay, thanks, Councillor Mackinson-Saunders. So first of all, on Skegness and kind of East Coast, Louth, etc. Absolutely, you're right. Quite a lot of the kind of structural, dare I say, large-scale investments have gone into sites that are in other areas. That's largely driven by some of the kind of backlog and some of the investment that's been absolutely necessary at the time. However, new community diagnostic in Skegness, redesign of some of the ward space at Skegness, and we are lobbying really hard for a rebuild of the Skegness UTC as well, because we absolutely know that environment's no longer fit for purpose. And as soon as we get a view on that, we will obviously be in contact. We're also working really closely with the PCN on that side of the county, and I've had some very flavoursome conversations with Simon Lowe in Mablethorpe around how do we get the integrated neighbourhood team to site the right services to manage the kind of local needs of the population. And we absolutely know that one size doesn't fit all with the kind of population development. So whilst every area is important on the neighbourhood health model, one of the biggest moves that we're going to have to make on the neighbourhood health model is the work in the areas that you've described. And it's one of the areas where we're starting that work. That doesn't mean that other areas will be deprived from that, but it just means that some of the biggest challenges we've got to get, and therefore we get the immediate focus in those areas. So I'm sorry you don't see the kind of big structural things, but actually we've got quite a lot that's working underneath that will be coming through. On the MRI feedback or follow up on the report outcome, I couldn't agree with you more. So we've got to a point where you need to book another appointment to get the outcome of your previous appointment, and that's just that's just kind of getting us into a place where we're duplicating work. So that whole diagnostic pathway and actually getting access to your own data through our new electronic patient record and the shared care record and get into those reports is all the things that we're working through. But I hope there's a theme in the entire presentation today, which is we're working to decongest all parts of the system here and completely transform the way that we work. And I hope that's coming through. And similarly on the two questions you've just asked, it's ever present in those two.
Thank you.
Thank you. Any other questions? Councillor Morgan, you want to come back again?
Thank you. Thank you for indulging me. First of all, I'd just like to make the point that we're a scrutiny committee. That does not mean that we think that the staff in the NHS, in fact, on the contrary, we're here because we care about the NHS. It's the opposite. And I'm representing our community. I personally had a fantastic experience recently at Grantham Urgent Treatment Centre. I was amazed. I had to see Dr. Anne be treated and have dressing on my leg, and the service could not have been better. So I think that there is very much a mixed picture, and we're looking at, we're always seeking to improve. So we're looking at the worst cases. And I think it's important we make that point, that we know, I know we were looking at GP services, people complain, but literally millions of appointments are actually dealt with across every year, those that they're dealing with. So we're looking at the areas where we've got issues and we're trying to improve them, which is why I think we're here. I have got a question on that subject. Having been involved in the hospital campaign, etc., for many years, about 20 now, one of the things that constantly comes up as a theme is winter pressures. And every year we get the same thing, that, oh dear, we're struggling to get the resources lined up for winter pressures. We know we have winters. We know we have a high number of elderly people. So can we not be more proactive about how we manage and support those people? One of the concerns that we've had in the community is the reduction in acute care beds that doesn't tie in with the increasing demand and need. Especially at winter, and I can't help but feel there is some link to this with regards to the wait times, or especially elderly people now in our A&E departments. To just make that point really, and I'd love to understand what we're doing specifically to plan for winter pressures. But then separately, I have a resident who has a blood clot on his heart. He's hugely worried. It's a life-threatening condition, and what's really concerning, he's got to go on warfarin, and he's basically being bounced around the county to have the treatment and monitoring of the impact of the warfarin on him. His GP is refusing to deal with it. He says, I can't deal with warfarin. He's been referred to Grantham. He's been made to travel to Lincoln and beyond on an ongoing basis, regular appointments. So I'd like to understand what is happening in that specific area. Thank you.
Thank you, Councillor Morgan.
Thank you, Councillor Morgan. So, first of all, thanks for your kind words about the staffing. Again, we'll certainly take those back. But equally, there is a place for scrutiny, isn't there? And it holds us true and it keeps us to account. So absolutely accept and respond to the challenging questions. On winter pressures, if I'd have answered this question a couple of years ago, I'd have turned around and said that the NHS treats winter like a surprise. It's this thing that we're surprised about in the middle of summer, and then it happens, and then we're all caught out. We're in Lincolnshire, we're absolutely not in that place. In fact, Lincolnshire has probably got some of the most impressive winter plans that I've seen in any area of the English NHS. The challenges that we have is the extremities of demand and being able to stretch our resource enough for the very short period that it happens. And of course, if it's almost like if winter went on all year, then actually you could expand and keep that expansion. But because it's so acute and then it comes back down, you've got to be able to flexibly respond to that demand and then bring it back down so that we can keep inside of the operating envelopes that we've got. So it's incredibly difficult. However, last year's winter plan was better than the years before. It was commended by the regional team, and I think you see from particularly some of the performance numbers that we're in a much better place, notwithstanding the fact that we've still got more to do on long waits, on discharges, and on some of the experience pieces as well. Scrutiny for the winter plan itself. So nationally, we have to publish our first draft of the winter plan in September. They go to public boards in September, and then we get an external review. So we're peer reviewed on the winter plan. Next time we come, I'm more than happy to give you the outputs of that peer review and the planning. But planning has now become a continuous cycle. In terms of the warfarin issue that you mentioned, so first of all, if I can disconnect the individual, and with the individual's consent, I'd like to have a look at that myself, if you can pass the details on, if they're happy, to myself or Anna. In terms of warfarin clinics, so it's difficult without knowing the detail, but we offer warfarin clinics all over the county. And it depends what treatment regime individuals are on. Some people have to have warfarin weekly, some people have it bi-daily, etc. And if that individual's on an odd regime, they'll be fitting him into clinics. However, it's time for us to listen to the residents' experience and see if we can do something different. So please raise it with us if you've got consent, and we'll have a look at that.
Thank you. I have Councillor Wimhurst next, and then we'll wrap it up. Thank you.
Thank you, Chair. Thank you for the presentation there. And we've just been going through this. I've just noticed some stuff about the EDI and all of that kind of stuff we've got going on in here. How much is that going to be costing to sort of implement across the board and all that kind of thing? May not be relevant for right now, but I think it's worth asking.
Yeah, sure. So can I pick up the EDI point and return to what I can say, just to give you an immediate response, is, to the best of my knowledge, we haven't got a budget line exclusively for EDI deployment. It's part of our training programme. It's part of the value set that we've got as an organisation. But in terms of the specifics and a plan, if I may, I'll refer to our Chief People Officer and get back with an accurate answer for you.
Thank you. And there's just one other thing also with just regards all of the climate change, net zero stuff that we seem to have in there. How much is that costing as well, please?
So in terms of to the public of Lincolnshire, and on the Lincolnshire budgets, it's not costing us anything, because this was through an external grant that we were awarded. So I think you're talking of the Salix improvements that are on the Pilgrim site. So it's not costing the people of Lincolnshire because it's coming through a national grant, not through local budgets. However, what I would say to you is that this also is at the same time doing remedial works for our aged estate as well. So if we hadn't got the grant, we would have to be spending money on the aged estate and on the refurbishment of that estate as well. So we've got a double win here, where we've got an upside on our capital that we don't have to spend on that because we get the grant. And then secondly, that it's not money from the kind of Lincolnshire system that's paying for it.
Thank you.
I have it recorded that I would like to disassociate myself with that report. I think it's really important that we look at equality and diversity, and that everybody should be treated equally in our county. And I would like to be disassociated with any comments like that, and I'd like that put on record, please.
Thank you for your comment. I now have three questions of my own, please, Darren. First of all, can you expand on Lancaster Ward at Lincoln County Hospital, referred to on page 34 of our agenda pack, in terms of the number of patients using this ward and any metrics on how it supports patients moving into the community? That's my first question. Second question, on page 32, it says creating local integrated neighbourhood teams, a link to current secondary care services so we can shift the focus into the community. How will these neighbourhood teams actually work on the ground with GPs and PCNs? What will their actual work be? And third question, it was noted in the chairman's announcements that the move of follow-up orthopaedics would allow the space in Lincoln County Hospital to be freed up to allow the development and expansion of same-day emergency care services. But will this space allow for an improvement in the number of emergency patients waiting for more than 12 hours between decision to admit and admission taking place. I note from the latest stats there are currently over 1,000 of these a month, which is 35 people every single day, which seems to be a lot. 35 people a day waiting more than 12 hours between a decision to admit admission taking place. And if that's business as usual, obviously the concern would be how you ever cope if there is a major incident and you suddenly have 50 people coming to A&E because there's been a train crash or something like that. So those are my 3 questions. Thank you.
Thanks, Chair. So on the last one, I'll take the 35 people waiting each day on 12 hours and just check the accuracy of the data. And if that's error, I'll let you know. But if I start bottom to top and then come back up, then so the follow up and the SDEC. So essentially, at the minute, our same-day emergency care is a national function where we can either bring attenders back to be seen by specialised medical teams, or we can actually see them outside of the emergency department and not congest the emergency department. We've been constrained with our SDEC because largely it's sitting in a bay to the side of Fracture Clinic at Lincoln. And so moving the orthopaedics and Fracture Clinic allows us to put more people through SDEC. So undoubtedly, senior decision makers seeing patients in SDEC will both decongest the emergency department and by their very nature get to making more timely decisions and avoid admissions. So the answer without reservation will be we'll see a reduction in our 12-hour waits as a result of those changes. And as I say, I'll come back to you on the 12-hour wait numbers. The integrated neighbourhood teams, if I can refer you to, now I know your numbers are different to mine, but the top of section 3 of the report, which is the coloured pie chart, it's page 5 on my report, but I know your bundle's slightly different. So the green shout out box in the top right hand corner, essentially the integrated neighbourhood teams will be a multidisciplinary team of both district nurses, GPs, physiotherapists, occupational therapists, hopefully working with adult social care, so social workers, and then other professionals as required. And you can see in that section, the first 3 tasks are to start to look at how do we manage high intensity users in a different manner, and how do we get to them earlier, to start to look at what are the long-term conditions in each of the local areas, and for the discussion we're having earlier about Skegness and Mablethorpe, we know that the presentation in those areas on long-term condition is completely different to Gainsborough. So understanding those long-term conditions and then getting the consultants that look after those long-term conditions plugged into those services, hence the plug socket, just as an example. And then finally, the complex multidisciplinary team. So where GPs can see people, for example, that have got an exacerbation of, say, asthma, and normally would refer them to a respiratory clinic in the hospital. What we do is we basically put a complex multidisciplinary meeting in, say, once a week, where we can rapidly go through those cases. So that's how we get the consultants and the integrated neighbourhood teams to work together with GPs. So hopefully that covers your question on that. And then on Lancaster. So Lancaster was always a pilot. So Lancaster is a what we call a non-recurrently funded ward. So it's a ward where the funding is renewed every 6 months. What we've done with Lancaster is some of our complex discharges we've put there. So at any one time, 24 people can be receiving care on Lancaster, because that's the bed restriction on there. And we've seen a length of stay reduction of 30% for those individuals that are on there, because we co-locate therapists, occupational therapists, and also some of our community teams to get them out. We've been aiming for individuals of more complex cases that go usually to rehabilitation care or to care homes, so that we get them into those placements quicker. And we're under review at the minute to see whether or not we change that model for winter or whether we stick with that model moving forward. Hopefully that answers all of your questions.
Thank you for that, and thank you for answering all our questions. Much, much appreciated. So we've now moved to the end of the debate.
Could we ask a question about if there are emergency?
I'm sorry, I need to move on. We're out of time.
Oh, well, I just thought if the doctors go on strike next week, we ought to know what emergency measures are in place.
I'm sorry, we're out of time. Thank you. We now need to move to a proposal. Thank you.
A very brief one. I'm not going to go into it. I'm not going to say what I was going to say, but I'd just like to thank the person who wrote this report, and Darren too. We've just grilled him for 90 minutes, and this is such a good report. I think we've had a really good, thorough session. Thank you.
Thank you, Councillor. I was about to say exactly the same thing. Thank you.
A point of order, Chairman. This is the third time since May that I've sat in a scrutiny committee where the chairman has sought to, in my opinion, Chairman, apologies, stifle debate. As has been mentioned by our colleague over there, this is a scrutiny committee and the chair is there to facilitate, not to stifle debate. So I think I'm subbed onto this committee and I've been really impressed with the discipline displayed by colleagues in asking their questions. And as I've said in a previous scrutiny committee, it is about getting to the heart of the matter, not brevity. So I want to be on record as having said that. It's about the questions we're asking, the answers they elicit, not how quickly we can get through the business. Thank you.
Thank you, Councillor
Chair, for the record, can I add my agreement with that? This is a scrutiny committee, and I have to say, if I feel that I'm being stifled, I will contact the Chief Exec, because we're here to scrutinise, and there's no time limit on it. The other committees that I'm on are always at least 3 hours. This is scrutiny, and we should be able to ask what we want to ask.
Thank you, Councillor. I would point out that we are now an hour and a half into the meeting, and we haven't yet concluded the first item of scrutiny. Thank you. So I'd like to move to a proposal, please, that we thank the presenters from the NHS for their attendance, their presentation and their answering of our questions, that the committee welcomes the developments over the last year, such as the reduction in vacancy rates, the opening of the community diagnostic centres, and the completion of the first phase at Pilgrim Hospital's emergency department. And thirdly, that the committee records its concerns and views on ensuring appropriate and effective discharge from hospital, the rate of patient readmissions, in particular the number of patients readmitted after 78 hours of discharge, waiting times for some diagnostic services, and communications of their results. Do I have a proposer, please? Thank you. Do I have a seconder, please? Thank you, Councillor Mackinson-Saunders. All those in favour, please. All those against? Thank you. That's passed. I'd now like to propose we have a 10-minute comfort break to return at 11:42. Thank you. committee to take their seats, please? And we recommence. Thank you. Okay, we're now live streaming again. The meeting is reconvened after our comfort break. The next item on the agenda, item 6, is an overview of local mental health, dementia, learning disability and autism services. This item is found on pages 45 to 69 of the agenda pack and enables Lincolnshire Partnership NHS Foundation Trust, the county's main provider of mental health, learning, disability and autism services, to provide an overview of its services to the committee. Like the previous item, this report introduces the committee to an extensive range of services provided by the Trust. So again, I emailed members of the committee last week to ask for detailed or complex questions to be submitted in advance. 4 questions were received in advance. Again, if our questions today raise matters of detail, we will need to accept that the answers may not be available at this meeting. So I'd like to introduce our presenters who are here in person. Thank you. Chris Higgins, Chief Transformation Officer, Lincolnshire NHS Partnership Trust, and Joanna Walker. Would you like to present the report, please, in 10 minutes or so? Thank you.
Thank you, Chairman. Thank you for inviting us along. I'm Chris Higgins, and I'm Chief Transformation Officer at Trust. I've worked for the Trust for about 25 years. I'm a mental health nurse by background and has worked in various different roles, but find myself in the current role. So I've got a good understanding of the services that I'm talking about. So you've got the report. I'll just give you kind of some headlines I think would be useful just to talk through. So as a trust, we provide quite a broad spectrum of support services to all age groups, predominantly mental health services, but we do provide some services, specialist services for dementia, learning disabilities and autism as well. Helpful just to note in terms of our trust strategy, which we refreshed the last year, which has got, we've stuck with our vision, which is to support people to live well in their communities. And that really sits at the heart of what we do as an organisation, really trying to maximise people's life chances and really have as much independence as possible. We've got 4 strategic objectives you see at the bottom of page 46. And I think 3 of them are probably familiar, well, definitely familiar to us and probably to most organisations, which is deliver great quality services through outstanding people and make best use of the resources we've got available. But that 4th element there, the healthy population, is new for us. And what that does is really signals our intent as an organisation to take greater responsibility for the whole population's mental health and well-being. So not just the people who are referred to us, but also that wider population and what our role could be as a big organisation in the patch to really support people in a different way. We work as part of a system, so we don't work in isolation. We work with colleagues in the group, as we just were speaking to Darren earlier. And we've got a what's called a Mental Health, Learning Disability and Autism Alliance group that sits and meets regularly. That's chaired by our Chief Executive and works with a range of partners across the system to work how we can work together to really support people in the broadest sense across our community. Just a few bits just to say in terms of things we're particularly proud of and things that we've done to develop services over the last or recent past. We've done a lot of work over the last few years to transform our community services, and what that's done is previously we've got had quite traditional community mental health teams, specialist teams where GPs just referred into, and we've worked to create new teams that wrap around primary care. So we've now got mental health practitioners that work in primary care surgeries and a team of people that work around there, really bridging that gap so that GPs have the support they need and that people can get appropriate and timely access to mental health support rather than always have to speak to a GP and other colleagues in that sector. We've also done work through partnership work with our commissioning body, the ICB, and the community and voluntary services sector to set up a series of a range of different options and opportunities to people. So from community groups right through to kind of social prescribers and community navigators to help people to access the right kind of support in their local communities as well as the services that we provide as a trust. We set up recently the NHS 111 option 2 helpline. So that was a recent initiative that was rolled out nationally. So if you ring 111, press option 2, you'll get through to a local our service here in Lincolnshire, and we'll be able to offer advice and support, navigate people to the right appropriate service to meet their needs. Our urgent assessment centre, we particularly pleased if it's one of only a few in the country, and that we've seen now in the 10-year plan for the NHS, is that that's something that's been wants to be replicated around the country. And what that does is provide, in essence, a mental health A&E. It's an alternative for people. We've got a mental health crisis that can come to our assessment centre rather than going to the A&E. It's based upon the Lincoln County site, and that has a number of benefits in terms of providing a better experience for patients, more timely access, but also means fewer people have to attend A&E, which is obviously helps with their demand, and it means that EMAS, the ambulance service, can drop people off directly, which helps with ambulance handovers. And our police colleagues, who often would be sat in A&E waiting with people for mental health support, can now go directly there, again helping with policing time. So has a number of benefits, and obviously really importantly for the patient at the heart of that. Another initiative just to speak about is our mental health support teams in schools. Again, really high on the national agenda now to really get that 100% rollout across all areas of the country, so that every school has access to appropriate mental health support. We're about 50% so far in Lincolnshire, and we just take advantage of the funding as it rolls through, and ready to set each team up as we go, and in line to have full coverage by 2030. And in essence, that's a team of professionals working in schools, giving people and students and those children really early access, identification, help and support, so hopefully we can stop longer term problems developing in the future. A couple of bits to mention is talking therapies, which is a intervention for anxiety and low-level depression. Again, really high on the national agenda around expanding those services, and we've done that in Lincolnshire and continue to grow those services. And it helps in terms of people managing that anxiety and depression at an early stage, so that it doesn't go on to develop to more serious problems in the future. And really importantly, helps people to maintain employment or education, so that they can still continue with their daily lives. And we've had quite a bit of investment to increase and expand our children and young people services. We've still got more work to do on that, in terms of waiting times, other things which I'll mention in a minute. But again, really important that we've been able to expand those services, particularly in the wake of COVID pandemic, where we've seen demand rise. As any organisation, we're not without our challenges, not because of, but we've seen as a consequence of the pandemic that there has been increased referrals after that period, particularly into our children and young people services, particularly into our adult eating disorders, but generally across the board. That's put increased demand on our services. We've tried to work with commissioners to get the right investment and also remodel our services so that we're making the best use of the resources we've got available. Unfortunately, we have got waiting lists that are longer than we would want them to be. We've made some really good progress in that area. I think as we came out of the pandemic, and that we were quite overwhelmed by the number of people seeking support and seeking help and support. We've worked hard to get that down, and we've made some good progress, but still got a bit of a way to go. And that was picked up on one of the questions, I think, in terms of where we're at, in terms of the extra questions that came through. Other things just to say, when people are waiting, we're really keen that people get the support, so we prioritise assessment. So whilst people might be waiting for formal treatment to start, we prioritise assessment so we can just make sure people's needs are understood and any risks are understood, so we can make sure that those in the highest need get the help the soonest. And also we've put in services to support people while they're waiting. So we've got workers that can give people a call, just to check in with people to make sure they're all right, and signpost into other services in the community that might be able to support them whilst they're waiting, so we don't just leave people kind of hanging while services kick in. We've done some work around our out-of-area placement, so some committee council members will know that we had an issue in the past with a number of people having to travel outside Lincolnshire for inpatient care, which wasn't great for them, wasn't great for the Lincolnshire Pound. We've done a significant amount of work on that over the last few years. I can say today we're at 0. The issue we've got is it's quite volatile in terms of that demand, and we do find ourselves having to place people further away than we would like. So we continue to work on that, and we're just about to bring online later this year a step down accommodation. So again, the committee will be aware that previously we closed our unit in Grantham Ashley House as an inpatient rehab unit and set up a new community rehab team, which has been really successful. We're now using that building to be able to provide this step down facility so that people have got extra accommodation as that interim step before they go into more independent placements in the community. Just to mention workforce, that's a particular challenge, or has been for us, but we've made really good progress on that. You'll see some of the figures in the report there, that our vacancy rate is now down from just shy of 15% to just shy of 10%, so that's great. We obviously continue to work on that. That means where we've got vacancies, often we're reliant on temporary staffing. Some of that's really helpful, you know, some regular members of staff that would like to work in that way, but equally we want to have that as minimal as possible, really, and just use regular staff where we can. So we continue to work on that as much as possible. And then finally, in terms of main challenges, is around the financial sustainability of the organisation. Finance has been pretty tricky for us, particularly this year and at the end of last year. We've forecast this year a deficit position of 3.7 million, which is, you know, so I've been working in the services for a long time, and it's the first time I remember us being in this position. So, and that's created by a number of different factors, but ultimately we need to address that, and we are. So we've set up a programme called Living Within Our Means, which is a process of looking at our corporate infrastructure and back office functions to be as lean and as efficient as we can in those services to really protect the front line. And we've got some work that's been going to be rolling out over the next year around our productive pathways. So how we've been as productive as we can with the services that we're providing, are we really embracing the new technologies that are available and maximising those. So really driving that lean and efficient way of working to get on top of that financial deficit, and confident that we will. Just in terms of the future, and a link back to the strategies, that linked to that healthy population strategic ambition, we've been really considering as a board what our role is in that space, and absolutely we need to continue to provide high quality specialist services. That's the heart of who we are and our identity as a trust and our role in the system. But what more could we do as an organisation to support the wider determinants of mental health and well-being? So things like having a safe place to live, having a social network around you, having meaningful occupation, whether that's volunteering, education or paid employment. And we're looking at opportunities that we can create in the trust for people with a lived experience of mental health or learning disability or autism about getting employment, and how can we work with our partners in the community to set up alternative services, and what could our role be to influence that and enable some of those things so that people really have those important factors that we know really affect somebody's mental health, as well as the specialist services that they need. So I'll probably leave it there, but happy to take any questions.
Thank you very much. So we now move to questions, and I have Councillor Arminger, please.
Before I start, I want to make a declaration of interest. I actually work for LPFT, but I do have a question, if that's okay. In your report, you mentioned the Norton Lee development. Is living within our means, is that going to affect that development in any way?
No, fortunately, we were able to secure external funding outside of Lincolnshire from NHS England centrally to be able to fund that development. So that's been really helpful. The reason we did it is because the accommodation for inpatients in Boston at Ward 12 is not fit for purpose. It was built back in the end of the 90s when we came out of the big asylums. And, you know, people aren't aware, currently it's a dormitory ward accommodation, so 5 people to a room with curtains around like a traditional ward. But obviously when you're experiencing significant mental health problems, that's not a great place to get that recovery. And so part of a national initiative to eradicate the use of dormitory ward accommodation in inpatient settings, we've been lucky enough to work with the central team to secure funding for that development. So it is fully funded, and not the Lincolnshire pound.
Thank you. I have Councillor Pessell next, please.
Thank you, Chairman. I note in regard to neurodiversity and late diagnosis autism, there's been a considerable uptick. I'm just wondering how much sort of outreach work is being done in that area to highlight the existence of such issues, and whether to an extent that could actually become a self-perpetuating issue, particularly as if it's very easy to go online for information and get a degree of misinformation based on those sort of community outreach issues, so that can create more unnecessary work, which would be a detriment to actual patients. And just as a second part, you may not be able to answer this today, but I would be interested in terms of statistically how today's patients, particularly those on the younger end of the scale reflect in characteristics compared to historically. So are, for example, issues such as long-term health conditions, gender dysphoria, issues from being in care, and the dangers of social media providing a degree of increased risk or diverse problems compared to historical trends.
Thank you. So just picking up the first question around autism, I think there's a couple of bits to that. One is we've seen, as mentioned in the report, a significant increase in the number of people seeking diagnosis, and that's as we put more resource into that, the demands just continue to grow, and it seems to be, it's outpacing us to a certain degree. But we're on top of that now, and we're trying to get those waiting lists down, but it's kind of quite a constant struggle, I suppose, just to keep on top of the demand as more and more people identify a potential need and seeking diagnosis. We're currently commissioned to provide diagnosis in a 6-week post-diagnostic support service for people, but that's all we really, our current role is. I think your point about outreach awareness is really important, and that really signals, I suppose, up until now, as a provider, we've just provided the services we're commissioned for, so diagnosis and 6 weeks post-diagnostic support. But in our new strategic ambition around taking more responsibility for the wider population, I do see a role for LPFT in what we can do to really educate and inform people of the facts and figures and the right information, so that there isn't that potential for misinformation, or at least it's reduced. So yeah, really helpful point, and I think we'll think about that as we do the work around our role in that healthy population space. In terms of young children and young people, we can go away and maybe have a think about some of the demographic bits and the other factors you've said, but I think it's a combination of things. Some of it, whether we can pinpoint specifically to any one particular source, whether it's children in care, whether it's online influencers and through social media, but we do know there's a number of different reasons behind what's affecting children's mental health, and we do know that there's more coming forward than ever before. But we work closely with our local authority colleagues around the SEND agenda, and we've got a really good integrated offer in terms of how we support and wrap around schools, as I kind of previously mentioned. But we could probably have a look at if there's anything particular we can draw out in terms of those themes and trends, and maybe bring that back.
Thank you very much.
Thank you. Councillor Reeve.
Thank you, Chairman. About 10 years ago, I worked as a hypnotherapist, and as part of that, I was offered some training by Lincolnshire County Council, a course called Suicide First Aid, that was open to members of the public and interested professionals, pretty much anybody in general who had any concerns around working with people with mental health problems, which I came across quite a lot working as a therapist. The idea of the course was so that you weren't frightened of bringing the subject of suicide up with somebody. It was a great course. I don't think there was a great deal of cost involved. It was a Canadian course originally. It was prevented because of the dark nights in Canada. They had a lot of problems over there. It was rolled out over here for a short while. I don't think there was a great deal of cost involved because I think there was one psychiatrist and one mental health professional that presented the course for 2 days. But I don't know of anything that still exists like that. Is there something that exists around that that's available at all?
I think yes. We'll check out the details. We'll be able to forward them on. But we've got a number of different offers in the county. What we've done is we work quite closely with public health here in Lincolnshire, and they really head up our suicide prevention work. So obviously, as a mental health provider, our role often sees people at the lowest ebb and I suppose at the sharp end of when people are really poorly. But a lot of the work we're trying to do is that preventative work, exactly what you said, in terms of educating people. Through our own recovery college, which is a group of people with lived experience and other staff, we try to educate and support through that. But we can find details of any courses available and share them with the committee.
I would just add, as part of the work we're doing with public health, there is a free training course that we regularly signpost people to that is an online e-learning that we encourage everyone in our community to do. So I can send on the committee the details for that, because that's some of the stuff that picks up a lot of that difficult conversations, not being worried about saying the wrong thing that you talk about.
Thank you. I have Councillor Morgan next, please.
Thank you. Just first of all, point of order, actually, or point of information, that there is the mental health first aid course which is being run throughout the county, which I've actually taken part in, and it usually is linked to the church organisations or those people like the cafes who are working with people. So it's just worth looking to see if there's anything locally on that front. And that's a really good 2-day intensive face-to-face course. And my question, I'd noticed that you are providing support for the homeless in Lincoln. We've had quite a number of issues in Grantham with rough sleepers, and having met a number of them face to face, what's really struck me was nearly all of them had some form of mental health issues, but they were very difficult as a group to engage with. Apart from anything else, half of them didn't even have a telephone, which for what reason or other, they might have started off with one, but they hadn't got one by the time they were talking to me. And I wondered, what strikes me is that if somebody becomes homeless, one of the key criteria that's used, I have to say, I think it's shameful, but it's government policy and historic as well, to decide whether they will be given temporary housing is their health, and are they deemed, quotes, vulnerable. And part of that could be mental health, but it means that what's happening is housing officers are actually making some key decisions relating to providing support for those people. And if they decide they're not vulnerable, then they are literally on the street until alternative housing is found for them. So I wonder what work you're doing engaging across the county with our housing departments to try and address this and make sure we are, as far as possible, supporting these people and preventing them, in effect, ending up on the street. And then the other point that has been raised with our rough sleepers, most of them actually been housed but had lost their tenancies because of their other conditions. They couldn't maintain them, and they didn't have the intense wraparound support they needed. So I wonder what we're doing at that side of things.
Lovely, thank you. Really important agenda. It's a holistic health for the homeless is our service that's commissioned to be provided in Lincoln City. So it's a Lincoln service at the minute. We're gathering the evidence about how effective that is to hopefully demonstrate the impact so that we can roll that out in other areas of the county. Obviously, funding required, I suppose, for some of that. But we can see the real tangible benefits for people who are using that service, and we just need to be able to evidence that and present that forward to our commissioners. That service, I think you're right, is that it's a group of people that are often perceived as difficult to engage, and what our team is able to do is really develop relationships with those people. So they're out on the streets often working alongside people to really develop the relationships, so it feels that you break down that kind of professional barrier so that people feel able to access, and that relational work is really important part of what they do. From the housing side of things, we've recognised this as a real issue for us as a trust in terms of just some of our lack of understanding, I think, about the housing agenda. How do we advocate for our patients in that space in a really effective way? So just about 6 months ago, we appointed a housing officer who used to work for one of the districts, who's come with that skill set, so they can work alongside our teams to really educate our teams around what forms to fill in, who to have a conversation with, and they can do some of the negotiation. We found a real impact of that. And then just last month, I opened the thing actually, we did a housing symposium, we called it, hosted at Skegness, where we brought in providers from housing sector, the districts, and different health agencies and others around the patch, really just to talk about housing and mental health and how we could work together in a much more effective way. So as a consequence of that, our housing lead is now picking up a number of actions around how we can develop a bit of a strategy to help people. So yeah, really important. And I think that the point around kind of, often people have had housing and then lose it is really tricky. And then particularly for landlords about whether they want to house people who've got, histories that might not be necessarily in keeping with their usual kind of criteria. We're again, through our, I suppose, using our housing lead, we can have better conversations with landlords about what the risks are and how we can support. It's also one of the things that we're kind of currently thinking about, what else could we do as a provider, as an organisation, if there aren't the willing landlords out there for some people that we know have got real significant mental health problems, but housing's a barrier. Is there something we could do in that space that's differently? So that's really early stages of thinking, but we recognise the need, and we're trying to find different ways to try to bridge that gap.
Thank you. I have Councillor Smith next, please. Thank you.
Thank you, Chairman. The suicide rate in Lincolnshire is the highest and ranks second highest amongst all local authorities in England and Wales, which seems a bit of a shock and a sad state for the county. Do you feel this report will help with that sad statistic and help reduce that figure? Thank you.
So there's a number of reasons why the suicide rate is as high as it is. I say we, as an organisation, come into contact with quite a smaller proportion of those people, and unfortunately, people aren't necessarily seeking help early or don't want to seek help, or so we're not always in contact with them. So what we're doing is working with public health and other partners to say what are the broader issues here. We've got some rural support workers that we put in place a couple of years ago that really outreach into farming communities and some of the rural networks in rural patches in the county to try to help. We've also got a worker now that links in with travelling communities in other areas, so that we're trying to reach into areas where people might not have previously come forward and sought help at an early stage. So we're trying to break down those barriers, but there's more work to do in that. And part of the alliance I spoke of earlier that we've got running in Lincolnshire, we're working with public health and other partners to come up with different ideas around how we can tackle that. But it's a bit of a wicked issue, really, in terms of understanding the different causes and what we can do, but absolutely committed to that. And really, it's one of we've got kind of 6 strategic objectives as an alliance, and that is absolutely one of them, is to bring that down.
Thank you. Councillor Lee.
Thanks, Chair. First of all, thank you for a really good report. It's really thorough, and you've obviously come well equipped, ready to answer questions. So thank you for that. Mine are just very brief questions, really. First of all, if as an elected member we wanted to contact somebody about I'm looking at the services you offer, page 49, 50, all of that, especially if you're going out into the community more, can you give us a point of contact? My second ask is, I'm sure there must be quite a lot of councillors. I, for one, would love a deeper insight into this. I'd love a standalone session on it. That actually could be part of the induction thing, because there's so much in here that affects the way that a councillor deals with people. And I'm not sure if that would be appropriate. I'd really rather have it face-to-face. I don't like online sessions, whether that's in county offices, or I don't know that it's appropriate to go out to one of your facilities. But I'd really like a standalone session, and not just for us who are members of the council, but for all members of LCC, because all councillors are going to come across this. And the final thing, I just wanted to make the comment. You obviously made the comment about managing within a budget, but I would argue that money that's spent on people's mental health is absolutely money that's well spent. And the idea that it must be a huge challenge to come up with really good quality services that meet people's needs in a timely manner within a set budget, because where do you put those lines? So actually I totally sympathise, and I don't think there should, it's easy to say I don't think there should be a price on it. Maybe there should be less concern with the amount of money we spend, and rather more concern about if we're fulfilling the need. Thank you.
So firstly, drop me a message if you want to know about any of the services, and I'll make sure you get to the right person, so anybody's welcome to do that, so please. There you go. But yeah, feel free, and I'll make sure you get to be able to put you in contact with whoever necessary, or I'll answer myself. Happy to do a session on mental health and what we're doing and the different services we provide, if that's helpful. And more than happy to put that on, and more than happy to do that in person for anybody that's interested. So again, if linking with through Simon or Joe, and we can just work out what best to do. But more than happy to do that. And just thank you for your sympathy around the money situation. It's tricky, finite envelope, but we've got to be realistic, I suppose, in what we've got available, and all we're doing at the minute is trying to make sure that we make use of every pound that we've got in the best way possible, and that we're being as efficient and effective as we can be with that. So,
Thank you. I have Councillor Welby next, please.
Thank you, Chair. Mental health is a very broad spectrum, and your package of measures is very broad. What really concerns me is those people that have significant and acute mental health issues, such as those with bipolar and those that require 117 aftercare. I see that the package of measures that is actually on offer to those people is reducing. In the past, there used to be one-on-ones, you know, carers assigned to these people. And now all that is finished and been replaced with, you know, a very adequate and very comprehensive but very broad spectrum. I know that mental health issues have increased since the pandemic, especially amongst young people. But it does worry me, the more acute mental illnesses, how are they being addressed? I don't know much about Norton-Lee, even though I should, because it's Boston. But are there special units within there that will address this 117 aftercare issue as I see it? Thank you.
Thank you. So I think it's really important to say that serious mental illness, so you know, bipolar, schizophrenia, conditions such as that are absolutely the heart of what we do as an organisation. So whilst we're really interested in and ambitious around what we could do to support broader mental health problems in the community, serious mental illness is our bread and butter, and that's what we're about. So the majority of our services are engineered and geared up to support people with those conditions. So whether it's our specialist community teams, we've got a range of different specialities, or our inpatient services, that's the purpose of those, to really support people when they need it most. We just recognise that if we could get in early, do the preventative work, we might be able to reduce people developing those conditions, or at least we might reduce the level of need when they've got those conditions. So our inpatient unit at Boston is an acute inpatient unit, so it's exactly for that really high quality inpatient estate we're building, so that when somebody's really acutely unwell and need that hospital admission, they would go to somewhere like our Norton-Lee development, or we've got similar sites in Lincoln and a unit over in Sleaford. So we have got those facilities when somebody really needs it. That urgent assessment centre I spoke about again is something when the people in that level of crisis, they can go and access that. And again, we're working up a case to be able to do something over in the east of the county and other parts, because obviously Lincoln's a long way for some people. And then we have other specialist services, so things like we've got mental health practitioners sat in our A&E departments in the hospitals, so that if anybody finds a way there, they've got a physical health need, but also mental health need, we can really support with that serious mental illness. In terms of 117, it's a complex picture, as you're probably aware, is that it's depending on the need, it's sometimes a joint package of care that's funded through social care or through health. So that's often negotiated with our clinical commission, ICB, and the local authority colleagues. So, but at the heart of that is a person has the right to have the appropriate health care, and our role in that as a trust is often to be able to describe what that care package should be, and then apply for a funding panel to be able to authorise that. So.
Thank you. We'd like to come back. Yeah.
Yes, I agree with everything you said, but the length of time it actually takes to get these packages in place is just not acceptable at this moment in time. It can take years. And definitely months, and there is also a limit on the help that is actually given. I think that if this isn't addressed, then there'll be a lot of issues in the future with seriously and acute mentally ill people not getting the right help that they need. I am happy to hear that Norton-Lee, as I suspected, would have this acute unit, but I would like some more information brought to this committee maybe about the workings of Norton-Lee, and you know, when it's appropriate, of course. Maybe even we can visit from this committee. I'm sure we'd all be really interested in that. Thank you.
Yeah, if I may, so yeah, by all means, be welcome to come and visit the unit. I think it'd be great. Really proud of what we're doing there. But yeah, I live in Boston, so it's great to see some investment in Boston itself. So just in terms of the 117 packages, you are right. We've got people who are often waiting longer than we would want them to do in hospital for that package of care to be set up, and often those packages of care the market is managed by the local authority, so it's not something that we necessarily have direct control over. One of the things that we've done recently is recognising that some people can be in a hospital longer than we would want them to be whilst waiting for some of those things, is the development of the Ashley House step-down accommodation. That's really in recognition that we've got people in hospital who don't really need to be in a hospital setting, often taking up a bed for somebody that then ends up out of area. So actually what we're able to do through that is, as a trust, we're setting that up so that we can offer at least some greater independence while people are waiting for those packages. But what we're seeing is the market isn't always there for the types of care that people need. And again, what we're saying now is actually as a provider, in what could we do? So if the market's not there, is there something that we could do? But we're really at early stages of those conversations with local authority colleagues about saying, look, let's understand the problem, what's missing from the market, and then let's have a talk about what we might be able to step in. But absolutely, we've got people in the hospital longer than we would want them to be.
I have Councillor Mackinson-Saunders next, please.
Thank you. Well, I just wanted to say thank you to the thank you for the suicide comments, but also to praise the Lincolnshire Rural Services Network because they do a fantastic job. Rural suicides are more than plenty, aren't they? And they do a terrific job. And I don't think they get enough praise for what they do. I was going to ask you, always flying the flag for the eastern part of the county, I know you're not going to be able to tell me just like that, where the 50% of the schools aren't that are being serviced. But if you'd like to send me a list of where within the eastern part of Lincolnshire, East Lindsey area, I'd be pleased to receive that. I think it'd be quite useful, and it'd be useful to be able to help push it through our wellbeing board that we got the help we needed in the east of the county. The other comment I wanted to make was where you say that with older adult mental health and dementia services, it's a 5-day-a-week service, but sadly it's on page 64 of our agenda. Unfortunately, health is a 7-day-a-week thing, and you always get a crisis on a Saturday night or an early Sunday morning, and is there no way we could have a 7-day-a-week service? And I know the staff won't think that's a good idea, but so when people are in crisis, and it's always over a weekend, isn't it? So I just wondered if there was any way. Dementia is a very difficult subject to deal with for families as well, isn't it? So that was a comment I'd like you to comment on, please.
Lovely, thank you. So thanks for your comment about the rural support network. So I will feed that back. Yeah, absolutely. We can get you a map of the mental health support teams. You can see where they are now and where the next phases are likely to be. So, and then in terms of dementia, just it's helpful to know just in terms of what different services available for dementia. So our community mental health team for dementia does operate 9 to 5 Monday to Friday, but we also have an intensive home treatment team for dementia, which does operate 7 days a week. 8 till 10, and then beyond that, the idea is if somebody can't be maintained safely within the community mental health team, they could step up to that extra level of support in the home treatment team, and if they can't be safely managed within the hours of 8 till 10, 7 days a week, we're then looking at 24-hour care in an inpatient thing. So we do have that kind of stepped model of intervention. It links back to an item in here in terms of Grantham, the unit at Manthorpe Centre, and we've got a paper coming back at a later date about that because we've temporarily closed that unit to allow us to have that 7-day-a-week service that covers the county. But that's been going through a process of engagement consultation. We'll be bringing the outcomes of that through, but we can see the benefit of that 7-day-a-week, as you say. It's people don't just get ill on a Monday to Friday.
Something, Mr. Chairman, because I find from the people I know who are dealing with dementia, it's the families who need quite a lot of support. Do you have somewhere where families can go for help and support? Because there's a lot of unhappiness and people don't really understand, do they?
No, absolutely. So a lot of our work as a trustee is actually working with families, certainly in that dementia area. So we work quite close with families. There's family support groups and there's carer support groups that are available, and we work with a lot of the charities in the patch who offer those services. But again, it's something that we want to do more of. There's never quite enough, is there, when you look at it, and everybody's supporting the way we want to do. But there are groups available, and again, we could probably share you some details of those if that'd be helpful.
Thank you. Councillor Morgan next, please.
Thank you. First of all, can I very quickly ask, in page 50, you're referring to the accommodation that you've got and you're looking for partners to work with you. Is that Ashley House? Just clarifying. Thank you. What's your relationship now with the police, given that there was this edict regarding how far the police will engage if there is a concern about a member of the public? So that there was that question. And then on your outreach side, are you doing any work with farmer community and farm workers?
Yes, so just picking up your last point first, yeah, that was the rural support network we were mentioning there. A couple of workers that are dedicated to really outreach into farming communities and others. So yeah, really important to really kind of raise awareness and help people access services who might not do so under their own steam. In terms of police, yeah, so I think when the kind of announcements came around about the police working differently, I think there was a lot of anxiety about how that might work in practice, and we were quite anxious as an organisation about what that would mean. But actually, we worked really closely with the police. We've got a really good relationship with Lincolnshire Police. Chris Davison, who works there, we meet regularly with him as a senior kind of connection, and we've got kind of really good joint working on the ground. And what we've done is just work through those kind of protocols about who's going to do what in what circumstances, and really confident that we've got the right services in place to support people. And actually, it's right if you've got a mental health need, and you know, if that's the predominant cause of your issues, then it's right that you're seen by a mental health service than a police car turning up and supporting you in a different way. So you know, if necessary, absolutely the police are there by our side, but it's making sure we've got the right professional for the right circumstances. So yeah, relationships are great, and we work really closely with them. So yeah.
Thank you. As I have nobody else waiting to speak, I have one question to put myself. Do you think that mental health, learning disability and autism services were adequately addressed in the newly published 10-year NHS plan?
Great question. So we're obviously digesting the plan at the moment. What I would say, I mean, yes, we've got work to do to really meet the full ambitions of the plan, but the work we've been doing to date is absolutely in the right direction. So what you'll see in there, there's things around the urgent assessment centres that are specific for mental health as being hailed as something we need to do and roll out, and we've got one. We were one of the first sites to do that. Mental health support teams, again, really important, as we talked about. The bit around kind of sickness to prevention, around neighbourhood working predominantly, the work I spoke about in terms of our place-based teams that bridge the gap between primary and secondary care, and the workers that sat in primary care really work well in that neighbourhood agenda. We're just going to be working with system colleagues. So Darren, who spoke earlier, obviously it's about the services they provide, how we provide ours, how GPs are working, and the other partners in the system, about making sure that we're all aligned in a different way. But the offer that we've got really lends itself to that, so I'm really, really confident about that. The analogue to digital piece, again, we've really worked hard as a trust. We've got an electronic patient record, we've got an electronic prescribing system that we're just re-procuring at the minute, and just be re-procured, and we're going through a process to try to link up with community pharmacies and other things like that. And we've just agreed a proposal to procure a patient portal, so patients can access online the services, can find information about the care that they receive and the services that might be available, can input into their own care plans, really importantly, which will be really helpful. So I'm confident there's still work to do around some of it to really understand the detail about how we're going to work, but I'm confident that what we've done to date really lends itself to what the long-term plan's talking about. So yeah.
And just to reiterate then, you don't think there's anything missing out of the 10-year plan? Absolutely happy it covers every base that you think it needs to cover?
Good. Well, never really thought about it that way, but I think there's always, I think from a mental health perspective, I think what the plan has done is it's, I suppose, adequately open for local interpretation, for us to be able to work up the things that we think are important for our local community, and I think that's really helpful. There's something about some things being really prescribed is sometimes helpful, but in circumstances like this, having some flexibility to do what's right for Lincolnshire is really helpful, and so that's where we're working. We've actually got a meeting this afternoon with the executives from across the NHS in Lincolnshire to work together to say, what does this mean for us, how are we going to implement this in Lincolnshire, make sure it works for us locally. I don't know, ask me again in maybe 6 months' time, and I'll maybe have a more informed answer on that. So.
Thank you, and I'm sure we will. I have no other speakers, so we'll move to a proposal. So the proposal is that the presenters be thanked for their report, attendance at the meeting, and for answering our questions, and the information presented be noted. That the committee welcomes the developments of the Mental Health Assessment Centre in Lincoln and the development of the North and East site in Boston, and the committee records its views and concerns on waiting times for treatments, the homeless person's access to services, and and Lincolnshire's suicide rate being higher than most other parts of England. Do I have a proposer, please? Councillor Mackinson-Saunders, thank you. Sorry, I saw you first. Do I have a seconder, please? Councillor Pessell, thank you. So all those in favour, please show. Okay, all those against? None against. Any abstentions? No abstentions, thank you. So that concludes that item on the agenda. Thank you again. And we now move to item 7 on our agenda, which is the work programme. Simon, would you like to introduce this for us, please?
Thank you, Chairman. If I could draw members of the committee's attention to the work programme report beginning on page 71, and on the subsequent pages are listed the items for September onwards. I think the main point, and I'll get this in first, is that we really need to identify something today for the October meeting, given the lead-in times. As the committee will see, there is only one item of business currently listed there. 4 for November and 3 for December, but I think I would really like to come away after this meeting so I can get in touch with someone and identify, so if the committee could identify a couple of items that I can try and get listed for that date would be, excuse me, very helpful. I won't go through all the other items because I'm sure everyone's read them, and I'll leave it there, Chairman. Thank you.
Thank you, Simon. Any suggestions from members of the committee? Councillor Lee, thank you. Councillor Mackinson-Saunders.
The winter plan, please.
Winter plan. Thank you. Okay, so the winter plan is down for November and you're suggesting we bring it forward to October? Yeah, okay. That makes sense, given that we want to do it before the winter takes place. I thoroughly understand that. Councillor Morgan, thank you.
Forgive me if I've missed it, but we were talking about maternity services, reviewing those. And the other thing is that they've come back publicly to say that they've made progress regarding the old Victorian hospital building at Grantham. They've had the consultation feedback. So I think they might still be in limbo about decision making, but I think it'd be really helpful to have someone go through what the result was of the consultation at the very least and what their plans are.
Thank you. Simon, you wanted to come in on that?
Yeah, the chairman's supplementary announcements covered I think it was only yesterday, the United Lincolnshire Teaching Hospitals Trust made an announcement on the outcomes of the engagement exercise earlier this year relating to the building. And basically, in summary, they are going to a next step, which will involve further engagement, but they're going to identify before that some options for the building. I think the clear point is that demolition of the building is not supported, but retaining the facade of the building as much as possible in a new facility tends to be what the public have supported. So they are going to work through some options, engage an architect, and that will then go through a process by the end of this year. So maybe it might be a bit premature in October. Thank you.
And of course,
could we add it then for later on, if we could do that?
Yeah, and of course we will report on progress in Chairman's announcements on every issue that I know members are interested in. I think Councillor Lee next and then Councillor Mackinson-Saunders again, please.
If we're going to bring the winter plan forward to October, can we then fit the parking one in the slot that's created? I just want to talk about it before we get to about next April, that's all. Thank you.
Okay, noted. Thank you. Councillor Mackinson-Saunders.
Our Integrated Care Board is going to disappear and we're going to be part of a larger conglomeration. Would it be possible to have an update on the progress and how that will affect our residents, please?
I think that's an excellent idea for October. Do committee members agree? I think we really want to keep a finger on what's happening there. Yeah. Okay, thank you. Councillor Morgan again.
Trying to understand when we are looking at maternity services.
Okay, it's on the list to be scheduled. I think really we need to let Simon see how long it's going to take to get a report together to come to us. Okay. To be honest, I don't think it's something that's going to be done quickly. We wouldn't want it to be rushed.
Okay, it's just...
Sorry, Simon.
I mean, I can ask the question if there was a possibility. I think as has been mentioned, I'm not sure whether it's in this paper or at last month's meeting, off the top of my head, that there is a national review underway. But I think some of the issues that have been raised are perhaps more about local delivery rather than issues of safety. It's what services are being provided rather than how safe or the quality of care. I think that's my understanding. Thank you.
Yeah, I mean, I've picked up, I think there's right, it's about the general provision of the services, but there is actually underneath that a potential risk element to it as well, a matter that's been brought to my attention, which is why I wanted it to come to us sooner rather than later. It's particularly whether we perhaps look at that one area rather than wait for a board report. It's particularly relating to late pregnancies and patient transfers and the risk to babies there. It's something I've picked up because Lincoln can't deal with them, and those babies are being referred in the first instance to Lincoln Hospital and then being forwarded onward elsewhere, which is to me hugely concerning.
Yeah, I think if we're going to cover it, we want to cover the whole issue, very much so. I take the point that Simon's made about, yes, we want to look at local issues specifically, and that doesn't mean we need to wait for the national review. So my suggestion would be that we try and slot that in November if we can, in the space created by what we're going to try to bring forward into October to fill the agenda for October, if that's okay with everyone. Yeah. Councillor Welbury, thank you.
Sorry. Thank you, Chairman. I know we've got dental services down, but I wondered if we could have just a special when it comes to dental work on children, because I have had various Teams meetings with the Healthy Living Board over the last 2 years regarding children's teeth and children's oral health in Lincolnshire, which is, as we know, the worst in the UK, or one of the worst in the UK. We don't seem to be moving very forward. There's lots of initiatives out there, Smile and such like, but they never go anywhere. And every time I have a meeting with them, they've got no more schools signed up than they did 2 years ago. So I wondered if we could have a sort of special part of the programme just for children's teeth and children's health, please. Thank you.
Thank you. We've got dental services in the programme. Simon, can you just advise whether that comes under children's scrutiny? Because anything to do with schools comes under them, doesn't it?
Well, certainly previous reports to this committee on NHS dental services, and I don't recall the last one did to the same extent, but prior to that, reports have covered children's dental health and provision for children and access of under 18s to NHS dental services. So I'm sure that that particular paper on the 19th of November, I think I can make sure that the presenters are aware of that so that they can cover that within that paper. If that's
would that be acceptable?
Yes, if you could, please. It's just that I know with the Healthy Living Board, it comes up time and again. I've had teams with the Smile people, and we just don't seem to be going anywhere with it. It's just sort of verbiage, really. I would like to try and move it forward so there is a positive outcome within the county. Thank you.
Thank you. Yes. Anybody else? I think we've got a general consensus here as to where we want to go with this. So I think Simon and I will be, and the Vice Chairman will be happy to basically try and get the agendas for the next few meetings together on the basis of the comments we've just made. Let me just move to the formal proposal. So the proposed action, we note the confirmed items of business of the forthcoming meetings as set out in section 2 of this report. We will try to make sure that we'll contact you in advance. We contact people in advance with a revised plan, can't we, before the next meeting? Yep. So we'll do that if everyone's happy with that. Do you have a show of hands on that? Everyone happy with that? To proceed on that basis? Thank you. Anybody against? Any extensions? Thank you very much. So that concludes the meeting, the business of the meeting today. Thank you very much for those who've attended. Thank you to our speakers, and thank you for those who watched online. Thank you.